Hello everyone, welcome back to Rapid Review for MRCEM exam. In this video, we are discussing questions regarding thoracic trauma. For a difference, I have recorded this with my A&E trainee Sam, who is appearing for MRCEM exam in the next couple of months. Hello, I'm Dr. Rahil, emergency physician, and I'm with Sam, who is A&E trainee. Today we are going to discuss 3 questions on the topic of thoracic trauma. I'm going to start with the first question. So Sam, just imagine you're working in A&E and you're seeing a 45-year-old male who is brought to the emergency department following a high-speed motor vehicle collision. On assessment, he is hypotensive with a blood pressure of 80/40, has absent breath sounds on the right side, and he is visibly in respiratory distress. Chest is resonant on the affected side on percussion. The question is, what is the most appropriate immediate management for this patient? Can you go through the choices and let me know what could be the correct answer?
Okay, so option A, obtain a chest x-ray. At some point I will probably want to do that, but because this patient is unstable, I don't think this is my most appropriate immediate management.
Based on the scenario, what do you think could be the underlying diagnosis?
So I'm thinking it's a tension pneumothorax, the fact that we've got absent breath sounds, but a resonant chest to percussion, is already in respiratory distress and is hypotensive.
Okay, good.
Option B, perform an open thoracostomy followed by chest drain insertion. That's definitely an option. So I know the ATLS guidelines recommend chest drain. C, administer high flow oxygen and observe. If this patient's tensioning, the high flow oxygen without any other management is going to worsen the situation. So it's not C. D, insert needle decompression catheter at the second intercostal space, mid-clavicular line. We've now moved it so that we generally do it at fifth intercostal space, mid-clavicular line, if we are going to do needle decompression. But for such a high-speed collision with an unstable patient, then this is less likely to be my option. And E, perform endotracheal intubation immediately. Again, this won't solve the problem if a patient is tensioning, so I would go for B.
And the good news is you are correct. Let's go through the options again. So the first option is obtain a chest x-ray. It is taught in all medical schools, is general expectations is tension pneumothorax is a clinical diagnosis and we should not delay the procedure just for the sake of chest x-ray. But the reality is, if you go on the NICE guidelines, it suggests in a patient with suspected pneumothorax, do the chest drain before the chest x-ray only if they are hemodynamically unstable. So here is the clinical judgment. So if someone who has got the pneumothorax but they are clinically stable, it is acceptable to get the chest x-ray if you can get it done quickly. The other better option will be to do the chest ultrasound, because most of the A&E department in UK, we have got the ultrasound machine. Most of the A&E trainees, they are trained to look at the pneumothorax on the ultrasound. That will be a better option. The reason for the decision is there have been lots of cases where people came to harm because of the wrong diagnosis of tension pneumothorax. And in a busy emergency department, sometimes it can be quite difficult to appreciate all the clinical findings. So going back, obtain chest x-ray is not the correct answer in this case because patient is hypotensive and the clinical presentation is highly suggestive of tension pneumothorax with hemodynamic compromise. You suggested option B is correct, which is open thoracostomy followed by chest drain insertion, and that is what is recommended by the NICE guidelines. Completely agree, administer high flow oxygen may support the patient, but that is not the definitive treatment. And the option D, insert a needle decompression catheter at the second intercostal space mid-clavicular line. It used to be the practice in the past, but now ATLS guidelines 10th edition, which is the latest edition for ATLS manual, is suggest going in the fifth intercostal space because the distance from the chest wall to the pleural cavity is much less compared to the second intercostal space. And with these studies is found there's a failure rate of more than 50% if you go with the second intercostal space. But here that is not the right choice because we are going to follow the NICE guidelines, which is very clear that patients with the tension pneumothorax with hemodynamic instability should have the open thoracostomy followed by chest drain insertion. And option E, as you suggested, which is the perform endotracheal intubation immediately, is not the correct choice. In patient with tension pneumothorax, if you perform the intubation first, it will make the things much worse. So the correct answer is option B, which is to perform an open thoracostomy followed by chest drain insertion. Well done, Sam. Okay, Sam, are you ready for the next question?
I am indeed.
Good. So just again, you're working in A&E, a 28-year-old male presents to the emergency department after sustaining a stab wound to the left side of the chest. He is hypotensive, tachycardic, and has absent breath sounds on the left side with dullness to percussion. A chest tube is inserted and 1800 ml of blood is immediately drained. Despite initial fluid resuscitation, he remains hemodynamically unstable. So the question is, which of the following statements is false? Can you go through the option and let me know, please?
Yeah, okay, so this gent's having a massive haemothorax. So, answer A. The most likely cause of massive haemothorax in this patient is injury to systemic or hilar vessels. I think that's quite likely. Depends on the position of the stab wound, but yes, I think that's an option. B. Flat neck veins in this patient rule out the presence of a tension pneumothorax. Sadly not, because if this patient is significantly hypotensive as a result of his blood loss, he wouldn't necessarily have distended neck veins. So I think that one is potentially false. C, an initial chest tube output of more than 1500 ml suggests the need for urgent surgical intervention. Yep, so I know there's 3 criteria for urgent surgical intervention. 1 is more than 1500 ml taken initially. 2 is more than 200 mils an hour for more than 2 to 4 hours, and the 3rd is a need for ongoing transfusion. So that one's definitely true. D, ongoing blood loss for 200 mil for 2 to 4 hours after chest tube placement indicates consideration for thoracotomy. So yeah, that's one of the 3 criteria I've talked about. And E, immediate blood transfusion is indicated to manage hypovolemic shock in this patient. That's definitely true. So of all those, I think B is incorrect.
Fantastic. That's a good answer. And that is a false statement. So this is very important actually to go through the questions very carefully and see what it is asking. So the question was, which is the false statement? And out of the 5 options, option B is false. Sometimes flat neck veins can give the false reassurance that it is only massive hemothorax, but people can have tension pneumothorax associated with hemothorax, and because they are hypertensive, they may not have all the clinical signs and symptoms of tension pneumothorax. So that we have to keep in mind. The only other comment I will make it, those people with hemothorax, hypertensive, we need to instigate massive hemorrhage protocol. And most of the A&Es, they can have negative blood or positive blood in the department, which can be started while we are waiting for the back from the blood transfusion department. So well done, Sam, you are correct. Okay, Sam, so this is the 3rd and the final question. So again, you are working in A&E, and actually it was a trauma day. So you saw another patient, which is 40-year-old male, who is brought to the emergency department with a stab wound to the right side of the chest. He is in his severe respiratory distress with decreased breath sounds on the right side and audible air movement through the chest wall defect. The pre-hospital team has applied a 3-sided occlusive dressing, but the patient remains tachypneic and hypoxic. What is the most important definitive management for this patient? My first question will be, based on the presentation, what do you think is going on here?
So I think this is a sucking chest wound or an open pneumothorax.
Okay, very good. Let's go through the option and let's see which is the correct answer. So we are looking at the definitive management for this patient.
Okay, so answer A, remove the occlusive dressing and reapply it with 4-sided taping, is possibly one of the last things I'd want to do. We're going to cause this gent a lot more discomfort and potentially tension.
Very good. So it will convert the open pneumothorax into tension pneumothorax. Good.
B, insert a chest tube remote to the wound. So that's definitely an option. I know that if they're classed as a large stab wound or open wound, then potentially we don't, in case they need to be used for a flap later. But if it's a stab wound, presumably from a knife, then that's small enough. So I would, this is definitely an option. B. And C, continue oxygen therapy and observe the patient closely. I mean, the patient is already unstable, he's tachypneic and hypoxic, so I feel he needs some more definitive management, so I don't think it's C. D, perform needle decompression at the second intercostal space. I don't necessarily know that he's tensioning currently, and like we talked about before, we do it in the fifth intercostal space, but I don't feel that D is going to be the option that I want. And E, administer high-dose intravenous antibiotics. Well, at some point this gentleman will need high-dose antibiotics, however, I don't think that's the most important definitive management, as that's not going to address his tachypnea and hypoxia. So I am going for B.
Well done again. So that's a correct answer. You have given very clear explanation, so I don't think I need to add anything else apart from the option of D, perform needle decompression in the second intercostal space. But here in this case, we are going with the chest tube insertion, so there's no need for needle decompression, and in open pneumothorax, you always go with the chest drain insertion unless like you're suspecting tension pneumothorax. And I suggested earlier, now if you go with the NICE guidelines, I suggest with the open thoracostomy with the chest drain insertion rather than needle decompression. So well done. So you have done very well for these 3 questions. We will meet again next time, and we will discuss another topic related to trauma. Till then, take care.
Bye-bye.
Thank you.